It's always interesting when I come to an orthopedic conference because I'm probably going to be the only female faculty there, I think. So, before we get on, I think the common point between arthritis in children and me, physicians, is that these are all children who present with joint pain. They're more likely to present first to you than to me. So that is precisely why you need to know, have an approach to know when children have arthritis and what needs to be done about it. So the first thing is a child who comes with, it's not working. Okay. A child who comes with joint pain doesn't always have arthritis. It's a very, very common mistake I see. Child has pain in knee, hip, etc., etc. Does a child have swelling? No. Okay. So unless there is objective findings, you don't call it arthritis. That's the basic tenet we carry on with. Now, a very simple formula to know how to approach arthritis in a child. So the first thing, is it arthritis or arthralgia? And we just went through how we confirm that. The second thing, is it acute onset, chronic onset? Is it involving a single joint or multiple joints? Is the child looking well or sick? And I think if you get this much down, it's very easy then to decide your DDs and how to proceed next. Is this child got only arthritis, or is this arthritis presenting in the background of a systemic illness? That's the next point. Okay, so now there are many causes for arthritis, but if we look largely at acute arthritis in children, for the sake of convenience, we say arthritis presenting less than 6 weeks is acute, and usually these children have a lot of pain, and usually this is related to infection in the form of either septic arthritis or a reactive arthritis or related to injury. Whereas if you're talking about chronic arthritis, where children have arthritic changes for more than 6 weeks, the symptoms are more of swelling and stiffness rather than pain. And that is something we have to elicit from our history. And this also, children presenting with chronic arthritis may look quite well otherwise. They might just have a limp sometimes. So that's the kind of thing that has to alert you to the possibility. Now this slide I wanted to put up because since 1997, the name has been changed to juvenile idiopathic arthritis. It is no longer juvenile rheumatoid arthritis. And what's in the name? Plenty. The main reason being we tend to think, if we keep saying juvenile rheumatoid arthritis, we tend to think that this is rheumatoid arthritis happening to little people, whereas the disease is completely different in children and completely different in adults. Children have a group of disorders, not a single homogeneous kind of disease. Children are rarely rheumatoid factor positive. And most important of all, children are getting arthritis in the background of a growing skeleton, where deformity and disability can be far worse if you don't attack it early. So, back to the definition. What is juvenile idiopathic arthritis? Onset of arthritis before 16 years of age, and you don't know the cause. So you might have a child who presents with a swollen limb with restriction, swollen knee with restriction of more than 6 weeks duration, who's had it after playing some game in school and has got a cartilage injury of the knee. Now you know the cause. This is not juvenile idiopathic arthritis. That is trauma-related chronic damage to the knee. That's why the idiopathic part of it is very important in this definition. So, what is the simple thing you need to know? You see a child, you suspect JIA, all you need to do is count how many joints are involved in the first 6 months. Less than 4, it's oligo. Less than 5, more than 5, it's poly. If they have the kind of presentation where they start with enthesitis, that is inflammation of the tendon attachment to bones, It's commonly the heel, the plantar aponeurosis, the quadriceps and other places. Start there, then develop lower limb arthritis, progress to sacroiliitis. This is the enthesitis-related arthritis group. This name has been changed. This used to be called juvenile spondyloarthropathy. The reason the name has been changed is because not all children who have ERA will go on to ankylosing spondylitis. So this is a much more common group. That's why it's been included this way. Now, history-wise, lots of things, but most importantly, as we said, the first three things, single or multiple, acute or chronic, any systemic symptoms. Trauma is very important. If it's pain, when is the pain maximum? Night pain is scary. You might need to think of malignancies. Is there morning stiffness? That is a classic symptom of inflammatory arthritis. Very, very classic symptom. And of course, family history and other things. Now, an examination, a detailed examination is important. Look at the child, well-looking child, sick-looking child, your DDs are different. And pain versus effect, that is to decide, the child says she has pain, do you think she has pain? There is often a difference in the physician's evaluation. Does the child have periarticular tenderness rather than restriction of the joint itself? This is particularly important in hematological malignancy, which can present to you as a monoarthritis. And hypermobility of the joints is important. This is a benign cause of joint pains, so the patient can just be reassured. And very importantly, I see plenty of these children who come to me on so many medications. When signs do not match the symptoms, always think functional. And these children have to be rooted in a totally different way. So, investigations. Really speaking, by the time you've done history and examination, you should have a clear idea whether you're dealing with arthritis or not. And then you can go on to what's the cause of the arthritis you're dealing with. If you're going to depend on investigations to decide whether the child has arthritis, that's going to be a bit difficult. It can tell you further how to differentiate causes and how to prognosticate, but not to decide whether the child has arthritis or not. So, a count can quite often be normal, especially in oligoarticular disease. You can get features of inflammation, anemia, leukocytosis, thrombocytosis helps if you get it. Or you can get this picture, which means you need to send to your pediatrician, ask them to do a bone marrow. ESR and CRP can be normal, can be raised. So the presence of normal counts in ESR does not exclude arthritis. Then all these tests everyone is very happy to do. The ASLO titer, what does it show? It is nothing but circumstantial evidence of a recent streptococcal infection. Unless you have the clinical picture of a reactive arthritis, an ASO titer has got nothing to do with the diagnosis. I could have a positive ASO titer today. I had a sore throat 2 months ago. That doesn't mean anything, actually. And in children especially, the ASO titer could take months to come down. So it can be completely irrelevant in a child who's got 3 months history of obvious arthritis. They will not have post-streptococcal reactive arthritis. Similarly, we know that the rheumatoid factor positivity in JIA is extremely low, so we cannot depend on that to make a diagnosis for us. The children who do have rheumatoid factor positivity are important to know because these might be going on to having adult erosive disease. Anti-CCP, very low. ANA, the only thing is whether there's an increased risk for uveitis. And same with HLA-B27. If you have the clinical background of an enthesitis-related arthritis, and you're HLA-B27 positive, you could be at risk for future ankylosing spondylitis. That's all. It's not diagnostic in any way. X-rays, changes are very late. Children mainly have synovitis, which you will not see on X-rays. By the time erosions come, there's usually some deformity. Ultrasound, MRI can pick up erosions early, but you can probably pick up clinical diagnosis earlier than that. Ultrasound is very useful for intra-articular injections and for tenosynovitis. MRI with contrast is the best test for detecting sacroiliitis in the early stages in children and for defining musculoskeletal infections. And synovial biopsies, really not routinely recommended, except where you have monoarthritis and you want to rule out TB. Now the very important thing here is the TB arthritis is always possibacillary. You're not going to get the bug from the fluid most of the time. Your histopathology may or may not be helpful. What really helps is sending a second sample of synovium in saline for culture, and that gives you the best yield. Synovial fluid examination, unlike adults, not useful in children except in septic arthritis. So you've done your basic approach. Now you need to describe what does this child have. Is it a chronic monoarthritis, an acute polyarthritis, and so on. This is monoarthritis. This is two joints, oligoarthritis. This is polyarthritis. Now, we'll talk a little more about monoarthritis because that is where there is really overlap between orthopedics and us. There are lots of DDs, being acute or chronic, and history and examination are going to help you differentiate between all these. Oh, sorry. Oops. Okay. Now, simple guideline, really. If you have more than one joint, I would say refer the child. It's going to be a medical problem, needs medical treatment. If you have a single joint, rule out orthopedic causes, osteochondrosis, whatever, the entire list we saw, everything, and then rule out, and then refer the child, TB, whatever else you might think. So just look at a series of patients who's presented with single joint pain and swelling and see what came of them. A 2-year-old who had a very painful elbow, sick child, febrile, won't let you touch. This is periosteal reaction, periosteal expansion, low counts, the child has leukemia. 10-year-old, this you will see plenty of, sporty child, painful knee. He was sent to me as an arthritis. He just had tenderness over the tibial tubercle, classic Osgood-Schlatter, back to the orthopedic surgeon. This girl was sent to me as a juvenile idiopathic arthritis of the knee, single knee, and 3 weeks duration, very swollen, painful joint, which is unusual for JIA. More than pain, it's stiffness, and very restricted. There was no initial history of trauma. They tried braces, NSAIDs, and oral steroids. I think the brace was taken off early, and then she was sent because she was not getting better. So we did an MRI, hemarthrosis, bony contusion. This is trauma related. When we went back, she'd been dancing heavily on that day, and that was probably the trigger. She just needed orthopedic treatment again. This child again, recurrent knee swelling, just single knee. Was treated by lots of people, given a homeopathic dose of methotrexate as well. Nothing was improving, and clinically fitted a possible diagnosis of juvenile idiopathic arthritis, monoarthritis. So I injected her because intra-articular steroids is the first thing you do for these patients. She improved very well the intra-articular steroids, but the fluid we got was blood-stained, which is very unusual. That makes you think of alternative reasons. So when she presented back with a relapse, we did an MRI. She has a lot of extra vessels, as you can see, the synovial hemangioma, and she's managed with sclerotherapy. And this is a child, 9 months, with a single wrist swelling, synovitis, effusion, restriction, morning stiffness, otherwise completely well. Had seen lots of people, had an MRI which showed chronic synovitis, a biopsy that showed chronic synovitis, but the penny didn't drop. Then finally she landed up with me, this is classic JIA monoarthritis, injections, child is doing well, but if you see, this is the right wrist which is completely normal, it's a lot of bony destruction here. There will be residual deformity. If she had come 6 months earlier, probably could have prevented residual deformity. So, simple management instructions, more than a single joint, just refer. Single joint, look for the DDs, especially acute, definitely rule out septic arthritis. And TB, try hard to prove TB rather than just empirical treatment. Drugs, just 2 more slides. The one thing I wanted to tell you is that the NSAIDs recommended in children are ibuprofen, naproxen, and tolmetin. And there are some certain specific indications for indomethacin. None of the others are actually approved for regular or long-term use. You can use briefly for post-operative pain, but not really in inflammatory arthritis. Steroids, again, if you're using steroids, you need to know why, which type, what dose, what course. And the first line of management in arthritis today is intra-articular steroids for induction and DMARD for maintenance. So why are we harping on about JIA? Because there are complications like silent uveitis, which can lose vision if not detected early, limb length discrepancies because of synovial hypertrophy and inadequate control of disease in the joint, and severe growth failure, short stature, and a lot of disability in children who are inadequately treated or treated with just lots of steroids instead of additional drugs. So just to repeat, it's JIA and not JRA. History and examination really are the cornerstone of diagnosis. No fancy stuff. And most of causes of chronic arthritis are medically treated, and early referral makes a lot of difference. Thank you.